to come to the stage right now and kick us off with our first panel.
So, thanks everyone, it's great to be here, and I'm really excited to host this important and very timely conversation on health system transformation through the lens of our theme for today, Ageing for All Ages. I'm Madeleine Brecken and I lead Communications and Government Affairs at GSK for vaccines, and I'm delighted to be joined by a diverse group of experts who's going to share views on how we can achieve this transformation from sick care to true health care. Now, as we've already heard today, countries are facing a demographic time bomb. By 2030, the number of people aged 60 years and older is expected to increase by a third to around 1.4 billion people. And while chronic diseases are taking a greater toll than ever, and infectious diseases are still spreading, barely 3% of total health spending is devoted to prevention across high-income OECD countries. Now, that underinvestment can be down to many factors, and I'm sure we'll be discussing some of those today. But it includes a perhaps concerning misconception that prevention may be more costly than treatment. But we know that preventable conditions are already costing G20 economies $1 trillion in annual productivity loss among those aged 50 to 64 years. So now we're here to discuss transformations needed in health systems in the face of challenges. And I think it's worth us reflecting on a very recent example of a challenge to our health systems and the impact that had. So through the COVID-19 pandemic, what we did see was great support for innovation, both in terms of diagnostics, treatment and vaccination as well. But what we also saw was great disruption to the health systems and a real test to the resilience as well, whether that was in limited access to screening services, maybe delays in interventions to stop progression of disease, and also a decline in routine vaccinations, both in infants and in adults as well. So a timely conversation for us to be having, and I think we should get straight into it. And Yosuke, I'm going to come straight to you first. So Japan is on the cutting edge of the ageing trend as the world's first super-aged nation. And as a councillor at the permanent mission of Japan to the UN, could you tell us a bit more about the work you're doing and how Japan has adapted its healthcare system to better serve its aging population?
Yeah, thank you very much. My name is Yosuke Kita. I'm representing the permanent mission in Japan here in New York. And I usually work in the United Nations on behalf of the Japanese government. And I'm originally coming from the Japanese Ministry of Health. And this experience provide me with the perspective in our healthcare policies, especially in national immunization programs and long-term healthcare insurance in Japan. And as you may know, that we enjoining our achievement of universal health coverage in 1961. And after that, in the year of 2000, we introduced long-term healthcare insurance. However, the age-dependent nature of these systems sometimes are increasingly have blow their kind of burden on the working age population. So Japan needs to shift the mode to the proactive mode to prioritize in preventive care and also evaluate the cost-effective analysis. And I once used to be a national immunization officer, and during my tenure, we added the pneumococcal preventive vaccine into our national immunization program, especially for elder population. And that move was based on the careful evaluation and the careful cost-effective analysis. And that understood that kind of vaccine can reduce the hospital admissions diminishing, significantly. So we decided that kind of move on our healthcare system, and also last year we introduced osteoporotic fracture preventions to our medical reimbursement system. That is that we set up the fee for the management of primary fracture patients to prevent the secondary fracture. So that would be the kind of our example, good example of our movement to the preventive care based on the cost-effective analysis. And in New York, I am working as a diplomat to promote the universal health coverage to all over the world. And especially after the COVID-19, people usually admit that the UHC is really, really important even after the COVID-19, because without UHC, we cannot estimate how many infected patients are in their own country. So, but promoting that UHC, we usually prioritize to keep this sustainable healthcare systems. We need to introduce the cost-effective analysis and to move to the preventive care in the early stage. So that is my work in New York. And so that's it for now. Thank you very much.
Great, thanks, Toshiki. And it's great to hear examples from Japan and your experience in Japan and how you're now bringing that to a broader audience. And I guess, Bill, I'll come to you next on that theme. So as the founder for Business for Impact and Professor Emeritus at the McDonough School of Business at Georgetown, and also former CEO of AARP, you've got a unique and broad perspective on these issues. And you've worked with a number of organisations on population ageing, including in serious illness and in transforming care. So building on Yosuke's introduction, what's the value of prevention to health systems? And maybe you could give us some examples that you've seen that prioritise prevention and healthy ageing as well.
Well, Madeline, first of all, I think healthier aging at all ages is a great theme for this conference. That's how people think. We have to think intergenerationally. So in virtually all cultures, certainly in the United States, older people, what do they care about? They care about their kids and their grandkids. What do young people care about? Their parents and their grandparents. So intergenerational solidarity is really strong. But transforming our American health system is a giant challenge. It's hugely expensive. Cost of care exceeds virtually every other developed country. The results are inferior to every developed country. But I think prevention can make a difference. I think it can make a big difference if we think about it broadly. So first of all, health insurance, access to care. If people don't have access to care, what do? They avoid primary care physicians. They stay away from the medical system. They end up in really expensive emergency room episodes. We've got to do something about that. And then care itself in this country is not fair. Care differs by geography, by race, by gender. We've got to do something about that. But I think with respect to primary prevention, we're short-sighted. So a lot of the prevention money in the Affordable Care Act never got properly allocated. We still have to deal with tobacco. It's a major killer in this country and even worse around the world. Obesity and overweight is growing. And I've worked a long time on tobacco, and I can tell you obesity is harder. It's more complicated. We've got to deal with opioids, with gun safety, with all these different issues that are part of prevention. And I want to give you an example that people don't normally think of, which is I represent the Coalition to Transform Advanced Care, CTAC. And this is about serious illness and end-of-life care. There is a huge gap between what people want when they're seriously ill and what we give them in our system. So what do they want? They want to be at home with their families. They want to have their pain and other symptoms managed. They want to have their spiritual needs addressed. And number one, they don't want to impoverish or bankrupt their families. In our system, we pretty much give them the opposite. We give them heroic care they don't understand. It doesn't prolong their lives. It doesn't improve their lives. And then they die oftentimes in institutions at huge expense to their families and to the country. Now, if we can help those people get what they want, not only will we have greater patient satisfaction, greater caregiver satisfaction. But as a byproduct, we will save money. So I think that's a good example.
I think those are great examples. And what I also feel about what you just said is we're talking about healthcare now, but you brought in so many examples of how actually the systems in economies need to work together and the value to productivity and so on. So Lotte, I'll come to you on that because you help lead one of the oldest independent health economics research institutions, the Office of Health Economics in the UK. So I imagine you think a great deal about the return on investments we're making for our health systems and the economic value of prevention in particular, which is ultimately at the heart of the transformation we need to see because of ageing, as we've just heard from Joska and Bill as well. So could you talk a bit about the economic drivers for us here and maybe what we know about the economic value of interventions, for example, in adult immunisation, for example?
Yes, thank you. And also realize being one of the oldest organizations in an aging society is quite something. It just struck me now. So, but yeah, so thanks for the question. So the economic value of adult vaccination especially is really, really very, very big. And particularly in aging societies where we see basically the triple-demic of COVID, flu, RSV, but also we see increasingly chronic diseases in younger populations. We see a backlog of treatments that has been mentioned already. And we also see like a very important increase in antimicrobial resistance. So just to name a few challenges that we're dealing with, and the value of adult vaccination should be really seen in this really big context. So what we see from the research we did is that the value of adult vaccination specifically is mostly understudied, sometimes also poorly understood, and therefore this leads to an underestimation of its value by policymakers and decision makers around the world. And to sort of help overcome that challenge, we today, just this morning, launched a report by the Office of Health Economics that describes the socio-economic burden as well as the value of adult vaccination across these 4 conditions in 10 countries worldwide, including the US, by the way. So that's up there, and I think there's a QR code, you can see it. So all the details are there. I'm just going to give you a very, very short summary of this. So the core drivers of value, as you asked, is basically there's 3. One is of the main value drivers is the impact on population health. So the diseases I mentioned, flu, RSV, but also herpes zoster and pneumococcal disease, they still have like a very high morbidity. There's many people that can be affected, sometimes fairly severely and sometimes people die. And vaccination is very effective in either preventing or reducing severity of the disease. So that's one impact on population health. Then secondly, the value driver on healthcare systems. If we can prevent people from getting ill or severely ill, they don't have to go into the hospital, which particularly in this time is very important given how overstretched hospital systems around the world really are. And then the third value driver, and this is the one that is mostly has the least compelling evidence yet, but we gathered everything that there actually is in this report. But this is really one that is still relatively less understood. It's the very broad socioeconomic value. But we do see the burden of these conditions on people's productivity, whether that's formal or informal, taking care of grandchildren, but also paid productivity, labor productivity, is tremendous. And therefore, having vaccination programs in place also for adults will help with economic growth, but also importantly, with more economic equity, because quite often more vulnerable societies, the underrepresented societies will value tremendously from those programs. So to sum it up, there is already an existing evidence base about the broader socioeconomic value that really supports some of the critical agendas also by the United Nations, WHO around this. But also there's some important gaps in the evidence that need to be addressed, and our report is just one step towards that.
That's great. And thanks for sharing the report, which I think we'll all enjoy reading later. So I'd like to shift gears a little bit and come to you, Lindsay. So Lindsay, at the Alliance for Ageing Research, you've been deeply involved in raising awareness around heart valve disease. And for those of us outside of this space, and maybe you can give more of the kind of patient perspective, could you tell us a little bit more about heart valve disease? And is this perhaps the perfect example of the need for some health system transformation?
Yeah, so heart valve disease is a type of heart disease that affects one or more of the heart's 4 valves. And some types aren't serious, but some can lead to major complications, including death. And there's around 11 million Americans that are impacted by heart valve disease. So it's definitely something that we need to be looking at. It's increasingly common with age. But we became aware at the Alliance that people just don't know what it is. We've heard of heart attacks, we talk about stroke. People just don't know what heart valve disease is. And in 2017, we did a survey and found that 3 out of 4 older Americans knew little to nothing about it. And that's a problem because one of the keys to timely treatment is detection. And if we're ignoring the symptoms, which I can get to later, but often are attributed to just a normal part of aging. So if we're missing the symptoms and we're not having proper detection and we are not getting proper diagnosis and treatment, it can really impact the outcomes. And this is why we started this Awareness Day campaign. So we started in 2017. We're joined now by over 120 partners. So we have foundations and advocacy groups and professional societies and heart centers and hospitals and some international partners as well. And we're all committed to being on the same message and sharing, really raising awareness about how important it is to be able to detect this in time. But to your second part of the question of, is this a great example for health system transformation? Well, this isn't a primary prevention example, it is a secondary prevention. And it's a field where we've seen tremendous advances in treatment. So it used to be that the only option was open heart surgery, and now there are transcatheter approaches where you can just go in with a catheter and replace the valve, and that really impacts length of stay and quality of life, and it will transform folks that say beforehand that they had these symptoms that were really disabling, and now they are back to how they were. So this field with tremendous advances, yet there's really inequitable access. And so to Bill's point, that we aren't seeing access across ages and across, we're seeing a lot of ageism and racism, I would say, in access. And so it gives us a lot of room to look at how people are accessing the care, how it's being detected, how they're getting diagnosis, and the treatments that they're actually presented with and then given access to. And there's a lot of barriers there, which I can talk about later.
Yeah, so on that, excuse me, on that, you're talking about barriers there, and actually I also think what was really interesting, you said a line around people accept it as a normal part of aging, and I think that's driving your need to drive awareness, and I think awareness maybe is something across many areas of health that is a barrier to people accessing healthcare. So just on that point, we're all saying that we have tools, we have arguments for better health and smarter economics, but we do still face those barriers across the systems to accessing health innovations. Maybe next we could all expand on some of those barriers to access health innovations. Maybe Yosuke, if I come to you first, if you have any thoughts on some of those barriers, maybe in Japan, but also what you're seeing more broadly.
Yeah, thank you very much. Actually, I would like to touch the importance of cost-effective analysis again, because for example, we are having the good innovation, especially for the dementia preventions. We have the new drug, but that kind of new innovation is usually really, highly pricing. So we do need to introduce a cost-effective analysis based on the robust data analysis. So, and I would like to, secondary, I would like to touch on kind of hesitancy in the people to their newly innovation. So I would like to touch my experience as a national immunization program to introduce the human papillomavirus vaccine in the 10 years ago. So we tried to introduce the HPV vaccine in 2013 in Japan, but we had a huge drawback from the people against the government because they are against the introduction of the human papillomavirus. So this is a kind of vaccine hesitancy. So at that time, we didn't, I need to confess that we didn't have the robust data analysis system, the adverse events of vaccine. So we cannot have good risk communication based on the robust data analysis. So I think that to cope with that kind of vaccine hesitancy, we need to have the robust data analysis systems and need to have the good risk communication based on that kind of scientific data. So that kind of infrastructure would be really, really important to have that kind of innovation in our prevention. Yeah.
So that access to data, both in terms of safety as well as on the HTA side as well. Lotta, I might come to you on that, because I know that that's something that, as you're doing research into how vaccinations in particular, but other health interventions are valued, that's a really important part, and how we can persuade policymakers as well.
Yeah, absolutely. We still see persistent gaps in adult immunization programs, also inconsistent access within and between across countries. So that is one of the main barriers we're trying to overcome. And like the WHO and all organizations, they call for national strategies to sort of overcome those barriers. But what is really needed is a good understanding that this is an investment, and I say the word investment deliberately, because most of these programs that have been studied in terms of cost effectiveness, either to the healthcare system or to society more broadly, they show they are highly cost effective and typically even generate net savings. So it's an investment. We get more out of it than we put into it. And I think really important, sort of breaking these barriers, is communicating that message and having that evidence available, and switching the mindset to seeing prevention as a problem for the healthcare system instead it is a net benefit for societies more broadly.
And Bill, you talked about some of those barriers of equity and access in your opening remarks. Any other thoughts on barriers?
Yeah, I'm going to suggest 4 barriers to innovation. The first one is investment in basic research. So I'm part of a group that released a report a few days ago called the Report on the State of Science in America. And what it shows is that government investment in research is declining as a percent of GDP in the United States. China's is going up, we're going down. Now, industry's research is still strong, but industry depends on basic research in order to do its applied research. And so we've got a problem here in terms of investment. Number 2 is education. So people have, well, we've talked about this, people have to understand and avail themselves of the innovations that exist. I used to be on the board of the American Cancer Society, and what they used to say is the demographic characteristic that correlates most with cancer control is a college education. Now, we can't have everybody go to college, but what we can do is educate and inform people, and we need to do that. And then disinformation. This is spreading very rapidly, and AI is adding to it. So when we talk about vaccine hesitancy, what we've got now is vaccine denial. And then also climate disinformation is growing very fast. Global warming is a health emergency. So disinformation. And then the last thing I would say is stigma. So if you think about different things, for example, lung cancer. For years, the tobacco industry would say, well, it's a legal product, smoke on your own. Oh, and if you get lung cancer, too bad. We've got to erase that kind of stigma. Another one is obesity, the stigma of obesity, HIV/AIDS. All these different stigmas need to be really addressed.
Yeah, really good point. And I think, Lindsay, you touched on that a little bit in your early remarks, that kind of how patients feel, their awareness as well. But any other thoughts on barriers of people accessing healthcare when they really need it?
Yeah, I mean, so sticking with the valve disease theme, although I would love to talk about vaccination another time too,
Yeah.
but one of the types of valve disease is aortic stenosis. So that's the narrowing of the aortic valve, and it's pretty common in older adults, can usually be successfully treated in all ages, but if left untreated, half of patients die within 2 years. But knowing that, we still see that less than 50% of patients with severe symptomatic aortic stenosis actually get treatment. So we know the treatment works, we know it's serious if you don't get it, and people aren't being treated. And so there's a lot of reasons why. I do think ageism is baked in, it's one of those barriers, and we have to look at how things like the assumption that it's harder to get up the stairs or get to the mailbox is just a normal part of aging, is impacting care in aortic stenosis, but in a lot of other diseases as well. And it's impacting the entire treatment pathway. But I mentioned racism as well. We know that there are higher rates of the risk factors and younger onset in minorities for valve disease, yet looking at the data for TAVR, which is the minimally invasive aortic valve replacement, we saw that from 2011 to 2019, only 4% of TAVR recipients were Black. And so there is a lot at play there, and I actually participated in a roundtable with the Association of Black Cardiologists, and they have a great white paper out on that, and talking about a lot at play there. But one of the things I wanted to mention is our payment policies, so how we determine who is getting what treatment. And with Medicare right now for TAVR, there's a coverage determination that has a lot of requirements. One of those is certain volumes for hospitals, and so that makes it so that smaller hospitals, rural hospitals, often can't give TAVR, and it's changing over time, but it really is presenting an unnecessary barrier. So I think we need to look at the things like ageism that are impacting us across the treatment journey, but then also what's impacting access, and a lot of our policies are doing that.
Yeah. And so on the policymaker point, I would agree that I would assume that no policymaker would disagree that these are all important barriers to be addressed. But how do we really convince policymakers before we get into a crisis situation? We talked about the impact of the pandemic, that investments in healthy aging will actually pay off. And what can policymakers do today to better integrate new innovations, whether that's technology, prevention, early diagnosis and treatments, into our healthcare system? Joske, what are some of the things that, in terms of, I mean, obviously you work closely with policymakers, what are some of the things that you think are the most convincing arguments?
Yep. In my experience, I also would like to raise again the importance of data analysis and good communication based on that kind of data analysis. As for the general education about our rapidly aging societies, we usually use the materials or demographic transition visually. So even for the policymakers, they do not understand what the meaning of demographic change in the next 10 or 20 years, but we can visualize how that kind of demographic change can impact our society by that kind of visual. So we can understand what the meaning of that kind of change of our society. So for example, our pension system and our medical health insurance system, also the long-term care insurance systems. As I mentioned before, this is very age-dependent system. So we need to keep our older age people by working age population. But we cannot understand exactly what this kind of burden is meaning in the next 10 or 20 years. So I think that can visualization of this kind of demographic change and also the data analysis can change the policymaker's mind dramatically. Yeah. So I think this kind of aspect is really, really important to change the policymakers.
Yeah, so data analysis, data modeling, data visualization as well. And Lotte, I guess that's something that's core to everything that you're doing.
Yeah, I think I very much agree with that. I can be quite brief on that as well, I think. So I think ultimately, as a health economist, what I think obviously is needed is like having better evidence around, you know, what does pay off, what are we paying for in healthcare, and how much help does that bring back to us, and also how much value to society more broadly, really also outside of the healthcare system. Like I said, prevention is not just a health system problem, it really is something we should look at more broadly. So that's actually what we did at OHG as well. So there will be a second report coming up at the beginning of next year, where we quantify the return on investment and the benefit cost of all these programs across all these countries. And also figuring out like what is really driving that value, what are the critical decisions that we have to make that really make something from moderate value to super high value and understanding. And that will help policymakers hopefully to digest that information and base their decisions on the type of evidence. Yeah.
So Bill, data is critical, but policymakers may also be human. What other arguments?
Well, we can dispute that.
Okay.
Data, evidence, you know, policymakers are especially challenging, and today more so. So I've worked at the local, state, and federal level with regulators, with legislators, and we're in a really divisive period, not just in our history, but I think in Western history. You know, we've got the culture wars, we've got budget fights, we've got presidential politics. There's very, very little bipartisanship. I found one thing that's truly bipartisan, and it's what I was talking about earlier, which is advanced illness and caregiving. So you go up on the Hill and you say to a senator, I'm here to talk to you about this issue, and the first thing she says is, let me tell you about my mother. So that's a bipartisan door opener. But we have to realize that that healthcare and health is one of many related subjects. For example, we've got in this country huge debt and deficit issues, and it's the cost of servicing our national debt is very shortly going to be one of, if not the biggest, budget item that we have. And healthcare is one of many related issues. I want to give as a prime example Social Security. You know, we used to call this the third rail of American politics. Social Security needs to be fixed, and it can be fixed. So I used to work with two U.S. senators, Kent Conrad from North Dakota, and a guy named Judd Gregg, a really conservative, flinty guy from New Hampshire. And they used to say, Social Security is math. We can fix it on the back of an envelope. And the truth is, it is math, and they could have fixed it on the back of an envelope, except there's one more thing involved, politics. And so all these things are just so very difficult. Innovations take time. They take major investments. An example are individualized cancer treatments, the new obesity drugs. But I think one thing is almost always true, and that is public support is necessary for policy change.
That's right. And it does touch everyone. Although I think I was just reflecting back on your first point, Bill, around what everyone cares about within intergenerational. I'm not convinced that my kids would say that they care that much about me and my parents.
They do, Madam.
Much more about Minecraft and having the next pair of Nikes at the moment. Lindsay, over to you on policymakers. I know a lot of what you're doing is arguing and making those arguments that to get policymakers to listen.
Yeah, and I think, you know, coming back to the economics argument, and also I think what David said in the opening remarks about quality aging, we need to make sure that what we're valuing with aging is also reflected in how we are providing access. And so one of the things that we're working on at the Alliance is looking at our value assessments. And so things like the QALY, that is the quality adjusted life year that is used to determine whether or not oftentimes we pay for something, has some inherent ageism baked into it. So the older we are and the more disabled we are, the less likely we are to be valued. And so we're really looking at how, you know, different valuations and even some of the proposed new valuations, which really are just disguised QALYs, have baked in ageism and are not only not valuing aging in the way that we all would like to see, but really are short-sighted in terms of savings. So if we're delaying care in, say, aortic stenosis, where it used to be, and I think still is, okay to watchfully wait a patient, we wouldn't do that in cancer, and we're talking about severe disease here. You know, there's some economic repercussions too. So we really need to look at how what we value is being reflected in our policies and our economics.
Yeah, and it's so true. There's obviously nuances for each of the different therapy areas we're talking about, but there's also so many commonalities across them.
Absolutely.
So conscious of time, I'll come to each of you now just for a closing thought. Yosuke, I'll come to you first.
Yeah, thank you very much. So Japan is now stands as our kind of the country of longevity, but with the rapidly aging population and with contrasted with declining birth rate. And this is a challenge and also an opportunities. So as for the osteoporosis prevention, one Japanese company is collaborating with the University of Tokyo to detect early phases of osteoporosis to prevent the osteoporotic fracture. And they are now using the AI's capacity to detect the early phase of the osteoporosis. And that kind of innovation could contribute to the repository globally as a pioneer to the aging society. So Japan and I would like to contribute in that way to the aging society as a kind of pioneer of aging society.
Yeah,
Thank you.
that's interesting. I think it might be something that's touched again later in the agenda. Lotta, anything else?
So yeah, my final message would be like really a call for a prevention first mindset. I think we need more investment in prevention, and adult vaccination is one important building block of that, but it's also broader than just that, of course. But we also need like the good, really robust evidence and about the full socioeconomic value of prevention and adult vaccination to go with that in order to really make better informed decisions. And then, of course, the politics, as you said, should play its part, but yeah.
Great. Bill?
Well, we've been talking about all these problems and all these challenges, and I have to say that I am an optimist. I really believe that we can achieve an aging society that's a net plus for all of us. I believe that. I'm also an amateur expert on retirement. I've retired many times. I always put that word in quotes. And I'm also an older worker. So yeah, we have a lot of challenges that we have to overcome if we're going to achieve healthier aging at all ages. But I really believe we can do it. And I think those intergenerational connections, Madeline, are going to help us. Now, research shows that as people age, they essentially want some basic things. They want health. They want financial security. They want to be able to contribute and to be productive. They want to be able to connect with others. And they want to have some fun in life. Those are the things that are basically universal. And people have a desire to leave a bit of a legacy. At AERP, we used to have a lot of research on this. And when I say legacy, what I'm talking about is leaving things a little bit better than we found them. Okay, that's not too much to hope for. We can achieve all that. It's inspiring. So I say let's work for that.
Thanks, Bill. Lindsay?
I feel like we wrapped it. I'm sticking with the valve disease theme. We talk about awareness, and it's not just for patients, it's also for healthcare providers. We oftentimes see that people aren't getting a simple stethoscope check, which would detect valve disease. So we need to really be looking at how ageism and lack of awareness is affecting the entire patient journey, and that's everyone that's involved in it. But also we need to be looking, just to underscore at our policies and making sure that they're reflecting how we're valuing healthy aging and what older adults want and retirement and for everything beyond, right?
Great. Thanks so much, and thanks to everyone on the panel. I think we started today with this focus on health, and I think more than ever, we know that getting ahead of disease is the best investment, and we can do that together for patients, for communities, for health systems and economies. And I think together we do have an opportunity to reimagine health, not just to treat sickness, but to invest in healthy aging for all ages. So thanks everyone, and thanks for listening.
So thank you, panel. And Bill, I realise I'm a failed retiree too. So